Welcome, everybody. We're really pleased to present Asthma Grand Rounds today. Ben Medoff and I are going to be discussing a pro-con discussion regarding remission is currently a legitimate target in asthma management. And to remind you, and we're going to be looking very much forward to audience participation because we think this is a very interesting and forward-looking topic. You can submit a question to our speaker by entering it into the chat. Nancy Lang, who I'm going to introduce in a minute, is going to be moderating this. And CME credit is now being awarded by the Mass General Brigham Office of Continuing Professional Development. You can email that at mgbcpd@mgb.org. So MGB CPD stands for Continuing Professional Development. So mgbcpd@mgb.org to claim your CME credits. And if you want to text for attendance, you can go to cpd.partners.org. Again, Continuing Professional Development. You can log in. You can choose Mass General Brigham Employee Login if you have an MGB username and password, or otherwise you can choose Visitor Login if you don't have an MGB password and complete the required fields. You click My Account, Edit Profile, your profession type, your mobile number, and click Save, and save the text to your phone number. Add the phone number 857-214-2277, the contacts on your phone. And this way you'll always be able to use the text to get your credit rather than having to do the emails as well. And that will work going forward. And if there are any questions, please, again, email MGB CPD, Continuing Professional Development, at mgb.org. The Asthma Grand Rounds are CME certified. This is a pro-con discussion. Remission is currently a legitimate target in asthma management. Remember the SMS code for attendance is to 857-214-2277. Once you've registered with MGB CPD, you should have that. And the code for today's attendance is CADYUW. I'll say that again, CADYUW. This is a course directed. We're considering the possibilities and barriers to achieving complete remission to asthma, and the activities intended for medical practitioners with a special interest in asthma. The course directors are myself and Chris Fanta, and I and Ben are speaking. And in terms of conflicts of interest, I'm a consultant for all the companies that currently produce approved biologics, which will be part of the discussion here in terms of thinking about remission. And I have clinical research support from these companies as well. And Ben is a consultant to Apogee and has research support from Regeneron and Sanofi. This is a live webcast. If there are any technical problems, you can get in touch with BWH Webcast Troubleshooting. So BWH Webcast Troubleshooting at partners.org. That's all one word for the BWH Webcast Troubleshooting at partners.org. And here are the Asthma Grand Rounds that are upcoming. So we're privileged to have Carlos Camargo talking about infant bronchiolitis and the risk of developing childhood asthma in September. In November, we have a roundtable discussion re-examining the role of GE reflux in poorly controlled asthma. We're going to have specialists in ENT and GI, as well as our pulmonary colleague who's moderating today's discussion, Nancy Lang Vaidya, talking about that. And in January, we're going to have Marissa Hauptman and Megan Sandell talking about addressing healthcare disparities in asthma. And in March, we'll have Using Airway Organoids to Explore Asthma Biology and Therapeutics by Ben Raby, which is an exciting new frontier. And then lastly, at the end, June, we'll have lessons learned from the precision interventions for severe asthma, exacerbation-prone asthma precise trial, and I'll be talking about that. So I think we have a great roundup. We look forward to seeing you for the future things as well. I'm going to turn this over to Nancy, who's going to moderate the discussion.
Great. Thank you so much, Elliot, for inviting me to moderate today. I'm going to introduce both of our speakers and then let them go ahead and do the discussion. As Elliot had mentioned, we're hoping this will be really an interactive discussion with the audience. So please feel free at any point to put any questions or comments in the chat, and then we'll talk about those after the two speakers are finished. So, Elliot Israel, you're probably familiar with already. He is the director of the MGB Asthma Center and the Severe Asthma Program at Brigham and Women's Hospital. He's also the director of the Pulmonary Function Laboratory and the director of clinical research in the Pulmonary and Critical Care Medicine Division and director of the Brigham's Asthma Research Center. He's the Gloria and Anthony Simboli Distinguished Professor in Asthma Research and Professor of Medicine at Harvard Medical School. Ben Medoff is a pulmonologist and principal investigator at the Center for Immunology and Inflammatory Diseases at Mass General Brigham. His research focuses on the mechanisms of lung inflammation and pathophysiology, utilizing animal models, cellular and molecular biology techniques, and translational human studies. So Elliot is going to kick us off here, talking a little bit about this pro-con discussion. We thought it would be a little bit less of a pro-con and more of just a debate about the risks and benefits of this strategy of remission in asthma.
Nancy, thanks so much for that kind introduction. Okay, so what Ben and I were hoping to do was split this up a little bit. I'll talk about introductions and definitions and kind of some of the potential foibles that we're facing. And then Ben is going to give you a really wonderful overview of arguments for and a more balanced view about thinking about remission. And I'm going to end with a little bit of caveats to think about as you read the literature and you hear referrals to the word remission. So how does Webster define remission? Webster defines remission as a state or period during which the symptoms of a disease are abated. And I think we all want to abate disease and abate asthma. So the question is, can you argue against motherhood and apple pie? Can we say that, gee, we're against remission? And I think we're not really going to be saying that we're against remission, but I think we are thinking about whether we need to think a little bit in a more nuanced way when we start talking about remission. And so when an idea becomes motherhood and apple pie, admiration can crowd out analysis. And the question's not whether something's good, but whether our assumptions about it are true, complete, and useful. So we're hoping, Ben and I, that after this, you'll think that you maybe have a little bit more of a understanding of what the nuances are in terms of thinking about remission. So the central problem with remission is that there's no universally accepted definition. So multiple expert groups have gone through and proposed remission definitions, and I'm going to review this a little bit with you. First from Menzies Go in 2020, then GINA, then German, Spanish, Japanese, and multiple others. I'm going to show you some of these, but there's no single globally standardized definition. So a meta-analysis found that remission definitions really vary substantially between studies, making cross-study comparisons unreliable. And so this is a big issue. You're going to see many shorthand things saying, well, we produce remission in this percent of patients, we produce remission in this percent of patients. And I'm going to show you that that very much depends on how you define remission and also what you use as a comparison group in terms of thinking about what really happens in terms of remission. So reported remission rates, and as a result of this, vary anywhere for biologics, anywhere from 13 to 43%, depending on which definition is applied. That's a huge range. And the same patient cohort, as I'm going to show you, can yield different remission rates depending on the framework that's being used. So the 2020 expert consensus framework got this ball rolling in terms of talking about remission. And in that framework, there were four kind of categories of remission. One was clinical remission on treatment. The other was clinical remission off treatment. And then there was a concept of complete remission on treatment and a complete remission off treatment. Now, in this initial proposal, the proposal was that remission on treatment should be defined as at least 12 months of substantial absence of significant asthma symptoms based on validated instruments, and optimization, stabilization of lung function, and patient and healthcare provider agreement regarding disease remission, and no use of systemic corticosteroid therapy for exacerbation or long-term disease control. So that was the approach to clinical remission. Clinical remission off treatment was the same criteria, maintained without asthma treatment for 12 months. And what about complete remission? So what did complete remission in the opinion of this framework was actually thinking about the resolution of inflammation in addition to meeting these clinical criteria. And they said in appropriate research settings, considering negative bronchial hyperresponsiveness. So loss of one of the hallmarks of asthma, airway reactivity. And complete remission off treatment would be the same criteria maintained without asthma treatment for at least 12 months. All well and good. Let me show you one of the other among the 7 or 8 different proposals for remission. So this was an asthma clinical remission published in the Annals of Allergy and Asthma. And this one said that all the following criteria must be met over 12 months and can be applied to those receiving monoclonal antibody therapy. So no exacerbations, all well and good. No missed work or school over a 12-month period due to asthma-related symptoms. Stable and optimized pulmonary function results on all occasions when measured over a 12-month period with at least 2 measurements in the year. Continued use of controller therapies only at low or medium dose inhaled corticosteroids or less, as defined by the recent GINA strategy. So no ICS-LABA, which is interesting in and of itself, considering what we know about MART. And then using these validated instruments, an ACT greater than 20, an AirQ less than 2, and interestingly enough, an ACQ of less than 0.75. And as you might know, in ACQ, an ACQ less than 0.75 represents good control. An ACQ of greater than 1.5 represents poor control. And so when you have an ACQ of less than 1.5, you're not considered to be in poor control, but not necessarily in good control. And these authors suggested that they wanted most of the criteria have suggested an ACQ of less than 1.5. These authors said, nope, they want an ACQ less than 0.75. And again, the previous 12 months with at least 2 measurements. And no more than, and using a beta agonist reliever, a beta agonist containing reliever, no more than 1 time a month. So what are these? I mentioned the fact that there are multiple requirements. Let's look at these. I'm just choosing 5 of these here to show you what the clinical remission criteria were. Here's the Menzies Go. Here's a German guideline, an Italian guideline, a Spanish guideline, and a Japanese guideline. All of them say no exacerbations. All of them say no use of systemic steroids. And then they start getting a little bit different in terms of symptom control. Now, remember, the Menzies Go was a little bit vague. The German guideline said an AC2 greater than 20, an ACQ less than 1.5. The Italian guideline, AC2 greater than 20. The same thing here. And then here, as I mentioned, the Japanese guidelines, they were going for a much more aggressive approach with an ACQ of less than 7.5 and an ACT greater than 23. In terms of lung function, and I'll talk to you about how this affects the way we think about potential remission. Menzies Go mentioned optimization and stabilization. Again, German stable or normal. And then in this case, the Japanese guideline, they actually wanted normalization of lung function, in many cases meaning FEV1 greater than 80%. The Menzies Go mentioned patient-provider agreement. The others did not. In terms of T2 biomarkers, remember this was only as part of complete remission, and the others agreed with that as well. And then bronchial hyperresponsiveness wasn't required. So what everyone agrees on, the easy part, no exacerbations for 12 months or more. And I caution you that you will see people publishing literature trying to say that they're that patients are in remission at 6 months, 3 months, 9 months. All of those are, I think, by most guidelines, unacceptable. No systemic steroid use for greater than 12 months, and some degree of symptom control. Then we start getting into the interesting parts, and let's talk about them. So should lung function be required? So some of these guidelines don't mention lung function, and we call that the 3-component definition. Symptoms, no exacerbations, no oral corticosteroids, and depending on which article you read and whether you define them as against placebo or not, maybe you can get 38% remission on biologics. In the same category, though, if you use 4-component definition, which says that you should have stable or normal lung function, and remember, some definitions actually insist that you have to normalize lung function, but here just stable function, meaning that in general, although that's not well defined, many people consider this less than 5% reduction a year. And then in the same study, when you use a 4-component definition, only 30% achieve on the biologic, and that's again not relative to placebo. So the problem is many patients have long-standing severe asthma, have irreversible airway remodeling, and will never normalize their FEV1. So these patients permanently excluded from remission, despite the fact that they're symptom-free, they're exacerbation-free, and and doing well. So some frameworks use optimization, stabilization as a workaround, but that's a little bit subjective and difficult to standardize. I threw out a definition, but that's not necessarily all agreed upon. So, while 3-point and 4-point definitions differ markedly in achievability, they don't differ as much in terms of predictors. And so this is a diagram of three-domain remission, looking at exacerbations, no long-term oral corticosteroids, and no exacerbations, and achieving control, here defined as ACT greater, ACT 20 or greater, or ACQ less than 1.5. So what are some of the best predictors? Prior exacerbations were a very good predictor. For every 1 unit increment, there was a reduction in exacerbations. Long-term oral corticosteroid use was a very good negative predictor as well. So for every 5 mg increment of daily oral corticosteroid use, there was a decreased likelihood of achieving remission. Your asthma control for each GINA increment was actually, interestingly enough, positively associated with this. And your percent predicted FEV1 for each 5 unit increment was also a predictor, positive predictor. Other things, your blood eosinophil count, doubling concentrations, was a positive predictor. Your blood IgE was not. Your FeNO was a little bit, although didn't achieve significance, and these were a combination of large studies. The other thing in this, asthma duration did not achieve this effect, although we'll see in other studies that it did. BMI was negatively associated. Smoking status was negatively associated as well. Interestingly, the use of theophylline was negatively associated as well. So this is the 3 components. If one looks at the 4 component, when one adds the percent predicted FEV1 as well, you can see that the lines here still have the same, basically the same set. So that what's determining this isn't, in terms of predictors, is not making a big difference either for 3 component or 4 component. And that may be that for many of these patients, they're being excluded for one of the interventions. The other thing is, so what are the appropriate symptom control thresholds? I've hinted at you this. The Menzies-Go framework basically implied ACT greater than 20 or ACQ less than 1.5. The Japanese, as I showed you, had an ACT greater than 23 and an ACQ less than 0.75. And remember, an ACT of 20 means well controlled, but not symptom free. And an ACT of 23 to 25 is closer to no symptoms. The ACQ threshold, as I mentioned to you, the 1.5, means not poorly controlled, but it's a far cry from what remission is in other diseases. And the other piece of this is neither the ACT nor the ACQ were designed or validated as a remission tool. They were developed to assess control. So the implication is a patient can meet the Menzies-Go symptom criterion while still having meaningful daily symptoms. And let's look at this in terms of percent achieving remission compared with pre-biologic very significantly by definition. So this is looking at a composite of the biologics. The gray lines here are the patient's pre-biologics. So this is not the placebo group, and we're going to get to that a little bit later. But this is pre-biologic to post-biologic. And if you define exacerbations as no exacerbations and no long-term oral corticosteroid use, you can see that by that definition, 50% of patients in the intervention arm achieved asthma control, achieved remission. If you start defining it as no exacerbations and no long-term oral corticosteroids and either well or partly controlled, so using our ACQ less than 1.5, you get down to 33.5. If you start saying no exacerbations and a percent predicted FEV1 of greater than 80%, you get down to 26%. And then if you get no exacerbations, no long-term oral corticosteroids, well or partly controlled, and percent predicted FEV1 of greater than 80%, you can see you get down to 20%. So we go from 50% or 33.5% for most definitions down to 20%. And again, this is the non-placebo compared data. What about biomarkers? So should they be required? So only complete remission requires biomarker resolution, and that tier is rarely assessed in clinical practice. A recent article by David Jackson and colleagues argues that this is a critical gap. Elevated type 2 biomarkers predict exacerbation risk and lung function decline, even in patients who appear to be in clinical remission. However, a counterargument might be that biomarker thresholds are poorly standardized. They vary by assay, and they're confounded by comorbidities. If you've got allergic rhinitis and nasal polyps, it may be very hard in the case of nasal polyps to get your biomarkers down to an area that we might define as remission. Now, should biomarker normalization be a remission criteria? This is an interesting article by Couillard et al., where they put together asthma attacks in the last year, no and yes, and stratified people by, in this case, on this side, their fractional exhaled nitric oxide. And what you can see is that even if you were well controlled, if you had and you didn't have two or more clinical risk factors, your risk for having an exacerbation increased markedly as your FeNO increased, or on the bottom here, as your blood eosinophils increased. And in patients who had high blood eosinophils and high FeNO, the risk for an asthma attack was still high, regardless of the fact that they didn't have clinical risk factors and that they'd not had any attacks in the past year, suggesting that, again, we may be wanting to think about biomarkers. So the other question is well-controlled asthma simply a rebrand with more aspirational language? In oncology and rheumatology, remission traditionally implies disease quiescence, often off therapy. In asthma, we're saying remission on treatment means the patient's still receiving biologics, inhaled corticosteroids, or both. And is that so? Are we merely just trying to downplay the fact that we really can't achieve remission? And then what about spontaneous remission? So 50% of children achieve clinical asthma remission by adolescence, especially boys. So should we be putting those patients on biologics to achieve remission? And in many cases, once you're on biologics, you don't come off. And then spontaneous remission rates in placebo-controlled trials are really substantial, and I'm going to show you that later, leading to reduced rates of additive remission versus placebo. So should we be treating patients early, which is what's being advocated, to increase the chances of remission, even if we treat patients who will remit spontaneously, is another question we need to ask ourselves. Lastly, there's a patient-provider agreement as a criterion in some of these things. But as many of you know who treat asthma, factors like BMI, sex, and psychological comorbidities can really affect the ability of some individuals to meet remission criteria, raising significant equity concerns about how we apply the remission criteria. And I'll just give you an example here from the Jackson article asking, are these patients in remission? So here's patient A, 2 puffs of albuterol per month on average, no exacerbations, low T2 markers, well controlled, but not in remission by the current remission criteria because they're using albuterol, 2 puffs of albuterol per month. How about patient B, exacerbated 9 months ago, now well controlled on dupilumab, blood eosinophils are less than 200, FeNO's 13. They're well controlled, but they're not in remission because they haven't achieved 12 months. And then how about patient C, exacerbated 13 months ago, blood eosinophils 600, FeNO 70. This patient would be in there in remission, but as I showed you based on the Couillard article, they're probably still at fairly significant risk for developing exacerbations. So I'm going to turn this over now to Ben, who's going to give you kind of an overview of how to think about this after I've raised these questions.
Thank you, Elliot. That was fantastic. Incredible review of what is I think, evolving concept in this field. And I think it's worth mentioning that a lot of this has been a follow-up to what's happening in rheumatology and GI with inflammatory bowel disease and rheumatology with rheumatoid arthritis in terms of achieving remission and stuff. And I think we're a little behind these other groups in starting to think about this. And, I'll just say when Elliot and I started talking about this and the pro-con, I think we kind of have the same sort of approach to this. So we're not going to really be in disagreement as much as discussing these differences. And it really is that I think we all agree with the aspiration of remission, right? I mean, as Elliot said, how do you argue against apple pie? But really it comes down to the practical aspects of this, which I think are complicated for sure. And, from my standpoint, as someone who does a lot of translational research, and I'll just bring this as a perspective, just from my perspective before I dive into these slides, is that, we do biopsies and brushes on mild asthmatics as part of our allergen challenge studies that we do on patients where we're taking these folks and giving allergen in the airway and trying to look at the immune response to understand that. But you can tell the asthmatics, these are often patients who just use albuterol occasionally, but their lung function's a little worse. It's still in the normal range, and their airways are thicker. And there are changes in their epithelium and immune cells that we can pick up. So you can look at those sort of profiles, and certainly their response to allergen is different. But there are changes there, even in these mild asthmatics, thickened basement membranes, thicker smooth muscle cells. And these are folks who I think you would consider well-controlled asthmatics for the most part. So I think, up front, is there damage that we are just not appreciating, because our treatment approach now is really about often responding to exacerbations, or smart therapy or MART therapy, right? You're not on therapy unless you're starting to have sort of symptoms, and it's sort of a change in the mindset to say that we're going to be moving, more into a preventative, and knowing that exacerbations are bad and exacerbations associate with worse lung function and other outcomes, and taking oral corticosteroids, right? I mean, I was looking up one trial that, even if you have one course of oral corticosteroids a year, every once in a while, your risk for osteoporosis goes up, pneumonia goes up, cardiac complications, right? So there is a downside to this idea that we'll wait for these problems to occur and then we'll treat them, versus we need to prevent these things from happening from the future. And I think that's the strongest case for remission in these sort of situations. And it's really about setting a higher bar here, more than just control, right? But reducing the risk of exacerbations and symptoms and inflammation, right? If we throw those biomarkers in. And it definitely, this idea really encourages what I think a lot of us do in tracking these problems. How often are you using your albuterol? What are the symptom scores? What are how often are you exacerbating? And the idea really here, and I think this is where the aspirational component comes and where we don't have the practical data yet, is that are there better long-term outcomes when we take this approach? Suppressing inflammation completely, low FeNO, no blood EOs, no sputum EOs. Are those people in the long term going to do better with less complications from their disease, less fixed airway obstruction and the rest? And we think so, but I think, as Elliot outlined, we really don't have those data out yet to really guide us in that. But from a standpoint of what we know from the data and thinking about it, it would seem that those would be the outcomes we'd expect from this approach. And I think that really makes the case for at least trying to achieve this and thinking more and more about it. I think we both agree that more research into this is definitely the way that we should be moving forward in the future. Elliot, you can go to the next slide. I'm trying to advance here, but you have the slides. So as Elliot, I think, outlined it, but the major reason I think this is really has come to the forefront in those of us who treat asthma is really the success of biologics, right? They clearly cut exacerbations, reduce systemic steroid exposure, they improve control, and spirometry gets better. And we do see, although it's a minority of patients, and I think Elliot showed the kind of 30 to 38% range, depending on how you define it, we do see people who do really well. And I think we all have patients on biologics who it's been life-changing, right? These kind of super responders who I still remember one of the first patients I put on a biologic 6 months later came to see me and was like, I feel like a normal person. And it really was such a life-changing thing for her that she went from constantly carrying an inhaler and doing this to being like, I'm normal. I don't even think about it anymore. And I think we see those folks, and it really has brought the idea that maybe we can achieve this remissions. And so I think these really have brought it in as a credible goal. I think this is different than cure, which I think is another really aspirational goal that we need to think about. And a lot of my research has to do with, how do you take this incredibly redundant inflammatory and structural cell pathways and find a way that you can actually truly reverse the asthma phenotype. But, we're not there yet. And so this, I think, is a credible goal in the meantime. Next slide, Elliot. So I just have this slide. This is a little bit of review from what Elliot went through. These are sort of a long list from a Lancet review or discussion paper where they looked at all the definitions of remission and looked at how well those did. And I think just the main point here is that it's highly variable, right? I think Elliot showed the kind of 38%, and you can see where that kind of falls out, but depending on how you did your definition and all these studies, you can see as much as 60% remission down to just, less, 20 or less for it, whether you use a 3-component or 4-component of remission. So remission is difficult to define unless we have a real consensus on how we do that. And as Elliot outlined, there's still ongoing discussions for what that remission will be. I think the 12-month standpoint point is a really important one because we do see seasonal variation with asthma. So just 6 or 9 months is not enough. I think, I just wanted to emphasize, I think 12 months really has to be the standard. And the rest, I think, including the biologic readouts, is going to need to be debated more as we move to the future. Next slide. This is also just, again, to make the point that I think Elliot already made, but just say it's hard to predict who's going to go into remission, right? I think in general, and Elliot, you can chime in on this, in general, the less severe cases are the easier ones with high EOs are the easier ones to induce remission by whatever definition you use, which may be not too surprising, but I think that's important to recognize, right? If you do have higher FEV1 and less exacerbations and lower symptoms, then that person is easier to put into these remission by these characteristics. Doesn't mean we shouldn't try, but I think that just is an important caveat to think about. Next slide. So, and this is sort of a summary of that shorter asthma duration, lower baseline impairment predict remission, higher baseline FEV1, inflammatory phenotypes, as you might imagine, since most of our therapies treat type 2 inflammation or type 2 high asthma, those things predict a better response. And, I think this really comes down to the idea that if we target early therapy, and as some experts are now recommending, target these folks very early. We can, I think there's some pediatricians on here, we can discuss whether pediatrics should be where we're thinking about this. Do we prevent a lot of the problems that exist from just ongoing smoldering inflammation with fixed obstruction and obviously steroid burden? Next slide. So what's the argument against this and giving you sort of a more balanced view? Again, I think this comes down to practical things. The definitions are still fragmented. As you've seen, lots of different definitions, varying symptoms, FEV1 thresholds, and all that makes this very hard to study. And until we have hard clinical outcomes based on these approaches, I think it's hard to make this as a definitive goal. And so that means we need to come up with clear definitions to kind of do this. And remissions still are uncommon, right? I mean, there are people who respond 30 to 38%. I think some people would argue that's still a pretty good outcome here, but it's not like we're batting 90% here can get people into remission. So we're using a lot of expensive therapies, require injections, et cetera, to get a minority of the patients into something we think may be important. And then I think this idea of a misaligned goal, means that is it a failure if someone's only using albuterol 2 times a month or 3 times a month? And I think that's an important consideration here too. And a lot of people are fine with that, right? And so until we know that that's really damaging, I think, should we first focus on the things that we have been doing, we know we can achieve, and then move this kind of into the later stages when we have more effective therapies and maybe cheaper therapies too. And then obviously comorbidities, as Elliot mentioned, is a really important component of this that makes it hard to often or confounds our ability to judge whether remission's achieved. Next slide. Practical concerns, I think Elliot mentioned spontaneous remission. There is also a really prominent placebo effect in many of these studies. So, does remission occur without active drug? And, are we over attributing how great biologics are for some of our patients? We know this isn't a cure, right? Relapse definitely happens if you stop biologics, exacerbations increase. This is true also in the rheumatology field. It's been shown in rheumatoid arthritis. You stop anti-TNF therapy, the joint deterioration and flares start to occur right away. Same in inflammatory bowel disease. So we're not quite at the point where we're dealing with a cure or remission as maybe an oncologist thinks about it, where you're off chemotherapy and cancer-free. That's not the case here. You go off therapy, the disease in most cases comes back. And how are we really committing people to lifelong biologics without knowing what that means over 20 years, et cetera? I think that's an important question. And then, of course, comorbidities and symptom perception and things like that may not track with what's the damage that's being there. We really have pretty crude measures. I can tell you, someone who spends their research time often in the airways of asthmatics. I think what we see in the blood and other things doesn't necessarily track with what we're seeing in the airways. And I think that's a really difficult issue that we just don't have the tools right yet to deal with. Next slide. So I think really, when you think about what would be an argument against this, it really comes down to costs and risks associated with it and equity too, which I think is important here. Treatment durations uncertainty, are we now committing people to expensive medications that, despite them being around for years now, we still don't know over 20 years, are we causing some sort of damage to folks? We're inhibiting fundamental inflammatory pathways. Is there a downside for that? And we don't know what we don't know right now for that. The burden is high. They're expensive, right? If we step down, I have a lot of my patients, right, who have cut their inhaled corticosteroid use. Some use it only PRN. I have a few who just throw it in a drawer. Is that okay? Are we, stepping down inhaled therapy makes, we know in some patients that can worsen FEV1, raise FeNO, despite them feeling pretty well. And, are we causing harm by actually controlling some of the disease and not others? And then, of course, there's equity and access, right? I mean, we're using this for really mild asthmatics, people who have access to pulmonologists, allergists, better plugged into healthcare, are going to be getting this therapy where others don't, and it's expensive. So you need to have good insurance, and your insurance has to approve it, and the rest. So I think those are all really important considerations if we're going to go down this road and make these recommendations. Do I have any more slides? Yeah. And so, this comes down to, my thoughts on it is, remission as a target. I think the idea of this as a North Star, something that we eventually want to get to. It's hard to argue that zero exacerbations, normal lung function, and no symptoms is not something we should be trying to obtain for all our asthmatics, and ideally off treatment. But, are we there yet? And what's the cost of doing that, I think, is really the important things. And, thinking about a more pragmatic approach here, and maybe that's something we can discuss in the last sort of 20 minutes here, is I think really the way we do this. And I think all of us would agree that we need trials now to know that is this something that's truly A, practical, and B, associated with the outcomes that we would hope it would. I think that's my last slide. I don't know, Elliot, if you had any further comments. Yeah.
Yeah. So, and just I was going to close up to just kind of at least think about how we can, in the snowstorm and blizzard of remission, how we can think about this in a more clear-eyed way. And what one needs to think about is when he sees the literature and he sees the promotion. So John F. Kennedy said the great enemy of the truth is very often not the lie, but the myth. And so let's just look a little bit at the caveats we need to think about. So beware the distortion of the definition. So I cannot tell you the number of articles I've gotten to review of late that say remission at 6 months, remission at 3 months, even, and where the distortion of this concept has really is escalating. So I think one needs to really you can see that all the consensus definitions, while there's a fair amount of variation, none of them suggests that you can really assess remission without 12 months of observation. And a lot of that has to do with the fact that exacerbations only occur sporadically. And so, and as Ben mentioned, 6 months or 9 months, you can avoid an allergy season. You can avoid other seasons where people exacerbate. So beware of studies that start talking about remission without 12 months. Beware comparisons using different criteria. You will see a lot of this, and where there will be claims that, oh, we induced 38% remission, we induced 45% remission, and other interventions only produce 20% remissions. Again, as you saw, there's very significant differences based on how you define remission. Beware uncontrolled studies without placebo rates. And let me show you this. And I actually misplaced this slide. This shows you what difference comparative rates of remission vary significantly by definition. This shows you studies with dupilumab, benralizumab, tezepelumab, mepolizumab, and multiple biologics. This shows you that depending on how you define this, you get very different numbers. So here, absence of symptoms. So remember here, some studies use an ACQ less than 1.5, others use an ACQ or an ACQ of less than 0.75, others use an ACT. Optimized stabilized lung function. You can see that in some studies, they said a post-bronchodilator FEV1 greater than 80%, post-bronchodilator FEV1 greater than 8%, a pre-bronchodilator FEV1 increasing more than 100 milliliters, no FEV1 criteria, and no suggestion of exacerbations. And look at the very big differences here, 31%, 36%, 26%, 43%, 14 to 28%, and down as low as 19%, depending on a Danish registry, but one that used FEV1 greater than 80%. So you need to really very much take with a grain of salt attempts to saying what these definitions are. But let me show you also the other pieces, which is the lack of comparison to placebo. As I mentioned, and as Ben mentioned, there's spontaneous remission. And we know from these studies with the biologics where patients are brought in and they're defined as severe asthma, and then they get randomized to placebo or they get randomized to the intervention, and then lo and behold, 15, 20, 25% of the patients who are in the placebo arm remit. And we're talking about 12 months of no exacerbations, no symptoms, at least by ACQ less than 1.5, and no oral corticosteroid use. And so I showed you the Lugogo article where they showed these very large differences depending on how you define them. But not only should we be thinking about how we define them, what are these actual remission rates, and what are we getting to with the biologics when we think about the placebo responses? And so this is an article that we published in the Lancet that looked at the comparison of the different interventions, and we restricted ourselves to studies where patients were entered with the same criteria, and where the same criteria were used for remission, and where subtracted out the placebo response. And so, for instance, in this benralizumab study, and you can look here at the benralizumab studies, Lugogo quotes, the rate of remission uncontrolled for the placebo was about 28%. However, when one subtracts out the control for placebo, the absolute rate of additive increase of remissions was only 11 to 12%. So the difference between putting somebody on a biologic versus, in this case of benralizumab, versus putting them on the placebo produced 11% more patients who were having remission. And what about the dupilumab data? So here's the dupilumab data, and again, showing about 30%. And then again, when one corrects that for placebo, there was only an additive 15% patients that actually achieved remission. And for tezepelumab, the same study, you saw 14 to 28%. And when you corrected for placebo, there was only a 7% additive effect. So one needs to really think about the fact that what are we doing? Which patients are we putting on this? And as Ben mentioned, if patients are going to go in spontaneous remission, are we sentencing those patients to lifetime biologic use without understanding whether they would have achieved remission spontaneously? And I think we're going to stop there and remind you how to set up your getting CME credits. And then Nancy will pose questions from the audience to Ben and myself.
Great. Thank you both for those amazing discussion points and clarifications of the different definitions and all the pros and cons of chasing remission in asthma. We do have a couple of questions so far from Chris Fanta, and I think one that is probably at the tip of everyone's mind after thinking about this is, does this make you think that we should be using biologics earlier in asthma, either earlier in age or even in patients with moderate or milder asthma? Should they be treated with biologics in order to achieve remission? I don't know, Elliot, if you want to start.
Sure. So the data suggests that patients who've had, as Ben mentioned, shorter duration of asthma actually are more likely to achieve remission. Those are also generally the patients who have less symptoms and frequently actually have are more biomarker positive. So the problem is, and as I showed you, the thing to think about is that the younger patients also have a higher spontaneous remission rate. So if biologics were $5,000 a year instead of $40,000 to $50,000 a year, I think we'd be having a different conversation. But I think that at the current rate of this and the thinking about the health system, the question is, should we really be pushing this on patients earlier? There are some data to suggest, but again, there's no really good data. The question is whether biologics are disease modifying, whether they reduce the more rapid decline in lung function. Now, remember that the average more rapid decline in lung function is really being pulled down by about 10 to 12% of asthmatics who have a very rapid decline in lung function. Actually, most asthmatics do not. So that again becomes an issue of what are we fixing? Are we putting 7 to 8 patients on a biologic because 1 out of the 8 will have a more rapid decline in lung function, and we don't have a good way to identify those patients? So I would, we're actually doing a study where we're looking at children aged 2 to 4, Wanda Fit Botanical and myself at Children's Hospital, where we're putting them on anti-IgE and these are patients who have a very high risk, 70% or greater risk of developing asthma, and looking at whether blocking their exposure to the external environment of allergens through using anti-IgE might prevent the development of asthma. But that's actually prevention as opposed to inducing remission. So I think the jury's still quite out about this, and I think we need to, and again, the issue for especially kids is where we know there's high remission rates is do we want to do this and keep patients on a long time?
Yeah, I'll just chime in. I agree completely. I think in theory, the remodeling that occurs, I think airway remodeling, at least in my mind, is one of these kind of black boxes that we just need more research to understand, right? We see airway remodeling in mild asthmatics, that's without question. How much of that is reversible? And just, I think about eczema, right? You put someone with eczema on therapy and their skin heals, and most of the time there's hardly anything there. And is that the case with asthmatics? I'm sure in some people you put people on biologics and the remodeling, and there are biopsy studies that show these things happen. But the hard question is like, do you prevent this decline in that important subset that Elliot brought up? And is that a reason enough to kind of blast people with these expensive drugs with mild and moderate? I mean, I point out there was recently a trial that was suspended for moderate asthmatics to try, for dupilumab because they couldn't easily enroll patients because so many of them were already on biologics. So it's happening already where people with not, the classic 2 to 3 exacerbations severe asthma who are on biologics, but we're seeing people on moderate dose inhaled corticosteroids maybe had 1 exacerbation and they're going on biologics now. So this is an important question to answer that I don't think we have have definitively know that whether that is true or not. But it may slip out of our hands too. The other thing I'd say is that we're constantly focused on monotherapy, and it is such a redundant. When we look, it's not just IL-5, right? It's not just IL-4 and IL-13. It's multiple pathways are involved here, and remodeling, of course, is growth factors, et cetera. And do we need to first think of a broader approach, again, thinking like oncologists with multiple drugs attacking a common problem, and is that going to be more effective too? And I think that also is something we need to think about as we move forward.
As a follow-up question and sort of related to what you mentioned, Ben, how do you both manage patients who've been started on biologics, are doing great, and their copay for their biologic is somehow low, and their copay for their inhaler is still $300 a month, and they stop their inhaler, and you tell them it's important to use your inhaler, but they say, doc, why should I use my inhaler? I'm feeling great, and I need to pay a lot of money for it. What do you say to that patient, Elliot?
Yeah, so that's a great question, and I think there's a cautionary note. There's a study called Shamal, in which patients who are on benralizumab, who were on MART therapy, and then stopped using their background inhaled corticosteroid, but continued to use MART, and those patients were reduced based on lack of symptoms, right? And what happened was that in a significant portion of those patients, remember benralizumab is an anti-IL-5, so it doesn't reduce FeNO. And what happened was that in a portion of the patients, the FeNO rose, and more importantly, the FEV1 fell. And these patients were saying that they felt well, but their FEV1 was falling, and falling dramatically, 100 milliliters or more, not just a little tiny drop. And that was associated, interestingly enough, with an increase in the FeNO. So I think we still don't know yet. And so look, the patients are doing it. We know that even in patients who aren't on biologics, only 25% of them, on average, they only do 25% refills of their background inhaled corticosteroids. So patients are doing this all the time. What I do in those cases is I say, okay, I want to be sure you come in. I want to be sure that I measured your FEV1. And if we're seeing a decline, then I think we need to have another conversation about what the long-term implications of this are.
Agree completely. I don't have any, yeah, and I talk to the patient, I say like, listen, as far as we know, you should stay on these. But as Elliot said, patients will do what they want to do. My cat's making an appearance too. So.
Right, and a plug. We're now doing a study where we're looking at tezepelumab, which blocks FeNO as well, and seeing whether that changes the equation. But I'm not sure it will. We'll have to see. I think that the jury is out.
What do we know about the predictors for spontaneous remission other than in children?
Ben, you want to take that first, or?
Well, I'll defer to you, Elliot. That's probably more of a.
The interesting thing is that they're not that much different from what we see in the biologics, which is again why, which is what needs to give us a little note of caution here, right? So the shorter duration, better FEV1, lower initial burden of symptoms. Those are all the patients that are more likely to have remission. The one thing that is different is the biomarkers. So, patients with very high biomarkers are generally, less likely to remit, and the biologics, because they're focused on these biomarkers, identify patients there where we know that is, Willie Sutton said, what are our banks? And he said, because that's where the money is. I have drugs that reduce this type of inflammation. The people that are most responsive are the people who have that great rate of inflammation.
Mhm. There are a couple of other questions here with us. So along the lines of the spontaneous remission of asthma, especially in children, how much do we consider this when starting children on biologics?
I think you need to consider it very carefully. And, at the very least, one needs to think about significant drug holidays in kids who've been started on this, right? Because we know that there's a really high remission rate in kids, right? And so, and we see this, and, it's very interesting because, we see adults who come in and say, I had bad asthma until I was, 13, 14, and now I'm here and I'm 35 and my asthma's come back. But I had 20 years where I had no symptoms. I was running track and I was doing great, right? And so, we know this happens, and it happens not infrequently. So I think if you're going to do this, I think you need to every year or so say, let's see whether we can take you off. And an initial failure doesn't mean that you won't have success 2 or 3 years later.
Do either of you have thoughts on using these biologics in asthma overlap syndromes, specifically COPD in asthma, or those with bronchiectasis who have more Th2 type inflammation?
In terms of, do we have thoughts of, definitely I use them in COPD overlap with where eosinophilic COPD for sure. I've had similar, not as many responses, but I have had a few people who have really nice responses to those therapies, reducing exacerbations, improving lung function, and the rest. Whether that's because they have asthma and also smoked, or truly is this, eosinophilic COPD. I'm not so sure. Bronchiectasis, I haven't had much experience. I don't know how much you've done, Elliot. So ABPA I've treated with dual therapy and, good outcomes there, but
Yeah. So, I haven't seen much bronchiectasis that is T2, that has, elevated T2 biomarkers. When that occurs, I think that that's, certainly potentially an aggravating factor. And so one could consider a trial to see that, because those patients can be particularly difficult to treat. And sometimes you could see how pathophysiologically you might think, well, if there's asthmatic inflammation, maybe that's resulting in decreased clearance of mucus and increased production of mucus, and that, that's harboring these organisms with the bronchiectasis. So maybe that will help. And then I agree totally with Ben. The COPD overlap. I think I tend to think of those patients as patients who have asthma and have smoked and have COPD, right? And you're treating their asthma component, which combined with their COPD is a really bad vicious combination, right? And so relieving the significant asthma component that is in those cases T2 centric can allow a lot of the background stuff that's going on to quiesce. And look, that's in COPD, the gold guidelines have changed over the past few years, saying that you really shouldn't even be using inhaled corticosteroids in patients who don't really have evidence, COPD patients who don't have T2 inflammation. And I think this is the same thing. We're basically recognizing that there's another orthogonal parameter here that aggravates COPD, and you can treat that, but you shouldn't be putting all of them on either inhaled steroids or even biologics.
Okay, great. I think we're at the end of the hour. So thank you so much to both of you for this great discussion, and thanks to everyone who participated today.
And Nancy, thanks so much for moderating.
yeah, thanks, Nancy.
Take care. Have a good day, everybody, and a good weekend.
All right, you too.
Bye.